Hello everybody, and thank you for joining us today for our special 4-part webinar series on managing hypertension and diabetes patients by mastering health IT. This is the 4th part of our series focusing on leveraging health IT to analyze data and improve hypertensive and diabetic outcomes. Our presenter today is Victoria Gallaty, and my name is Leslie Kiesel. Before we get started, I have a few housekeeping details to cover. First, we'll be keeping the phone lines on mute, but if you have a question, please put it in the questions box. If we're unable to answer your question during the presentation, we'll answer all questions within 1 to 2 business days via email. We'll also be posting a video and a PDF of today's presentation on mcida.org. For those of you that don't know, the MCEDA program is largely grant funded and run by Altarum Institute. Altarum is a nonprofit with nearly 70 years of experience researching, developing, and implementing solutions that serve the public good by solving complex systems problems to improve human health. Our staff members are leaders in identifying, understanding, and solving critical systems issues that impact health and healthcare. From designing and developing health information technology systems to working with healthcare providers to foster clinical quality improvements, Altarum is widely acknowledged by the federal government, the state of Michigan, and the private sector as a valued partner. We currently have over 400 employees across the country. Housed within Altarum, we are MCEDA, the Michigan Center for Effective IT Adoption. Originally born out of the HITECH Act, MCEDA is Michigan's regional extension center. We're tasked with accelerating the selection, adoption, and meaningful use of health information technology to improve the quality and efficiency of healthcare in our state. To date, we have assisted over 5,700 providers across Michigan, impacting 1.6 million patients annually. And 1 out of 4 Michigan providers who have been paid for meaningful use is an MCEDA client. Our services are highly subsidized for qualified providers. Paired with our fee-for-service packages, our services include meaningful use support, including any stage in any year, security risk assessments, targeted process optimization, which is an adapted version of lean principles that is applied to clinical or operational practice improvement initiatives. So no matter what you need help with in terms of improvement within your practice, we have the experts who can help. Finally, we have attestation and audit preparation assistance for those in need of one-on-one assistance before attestation or after an audit letter is received. In today's presentation, we'll take a few minutes to briefly discuss the health problems we're focused on, hypertension and diabetes. From there, Victoria will discuss the various ways you can leverage your health IT to help analyze and improve your current processes for better patient outcomes. Topics to be discussed include data management, analysis of data, models for improvement, the PDSA cycle, and a real-life example of the PDSA cycle in regards to hypertensive patients. In addition to the information in this educational series, our team has developed a customized toolkit to guide your office with the recommendations from our webinars. When incorporated with your current processes, these tools can help ensure accuracy and improve the health of your patients. We're going to post the tools on mceda.org, and we'll also email them out to the attendee list. And with that, I'm going to turn it over to Victoria to get started.
Thank you, Leslie. So, no one can argue against heart disease and stroke being incredibly serious problems. They are currently the 1st and 4th leading causes of death in the U.S., with over 2 million heart attacks and strokes happening each year in the country. 29.1 million people, or 9.3% of the population, have diabetes. The stats in our state are even worse, with an estimated 10% of Michigan adults diagnosed with diabetes. And an additional 250,000 Michigan residents are believed to be undiagnosed. As if that wasn't bad enough, the national and state statistics around hypertension are even worse, with approximately 70 million, or 1 out of 3 American adults, affected by high blood pressure. Roughly 16% of Michigan's adult population does not have their hypertension under control. With disturbing figures like these, it's no wonder we are continually seeing over 2 million heart attacks and strokes in our country each year. The strategies and tools we're discussing today can help to lower these alarming numbers. With the predominance of these conditions in mind, we'd like to introduce you to the model at the heart of this educational series, something called the Health IT Patient Management Model. In a nutshell, it is the PDSA, or Plan, Do, Study, Act cycle that leverages health IT to identify, engage, monitor, analyze, and improve the health of your diabetic and hypertensive patients. The rest of today's presentation focuses on just two of these functional areas, analyzing the data and using it to improve care. Additional sessions focus on the ways you can leverage your health IT to identify targeted patient populations, engage patients and healthcare teams, and monitor compliance to treatment plans. All right. Effective data management is the key to performance improvement. Collecting, analyzing, interpreting, and acting on data for specific performance measures allows you to identify gaps in care, to make corrective adjustments, and to track outcomes. The next slides, we will talk over data management, data analysis, and how to act on the data to make improvements in the delivery of patient care and patient outcomes. We will start with the basics. In order to have effective analysis of the data, we must begin at the planning stages of data collection. We must ask ourselves 4 fundamental questions. Why are we collecting the data? What is our ultimate goal? Who will collect the data? What data will be collected? And how will the data be collected? As previously discussed in other parts of the webinar series, we are collecting data to help improve the identification of target populations, improve quality and convenience of patient care, increase patient participation in their care, improve accuracy of diagnosis and health outcomes, improve care coordination, and increase practice efficiencies and cost. Identification and assignment of the specific individuals who will be responsible for the collection of data is vital to any successful data collection. In the clinic setting, we are fostering the team effort. In a successful team, we trust that each team member fulfills their responsibilities, communicates effectively and critically, are committed to achieving the team's goals, establishing accountability and focusing on the results. Therefore, it is imperative that each member of the team has clear instructions and assignments of their specific responsibilities related to the role in their data collection. Again, understanding and replaying your initial question of why are we collecting the data is imperative for this step. The data we choose to collect and analyze must be relevant to the goal and the purpose. It must be the right type, easily accessible, accurate, and reliable. Specific examples of this raw data include demographic data, smoking status, family history, or even medications and lab tests. For successful data collection, the process of data collection needs to be easy. Clinical data is extracted from a variety of sources, including electronic health records, information exchanges, disease registries, and even personal health devices and direct patient surveys. Data that needs to be collected for quality measures should be built as seamlessly as possible into user workflows. Users should also be aware of the data collection process and taught how to enter data correctly. Examining clinical data completes a 360-degree view, enabling providers to analyze their patient populations, understand which individuals need the most help, and proactively reach out to give them the care they need. When intelligently applied, clinical analytics help not only support a clinic's bottom line, but also improve patient outcomes. Great sources to pull raw data to use in identifying and monitoring patients are the patient and their family, EHR and patient registries, outside documentation collected from other providers, and shared through direct secure messaging. The key is capturing all raw data in structured fields to be able to obtain useful reports. Some great reports that can be run pulling raw data within the EHR are tickler lists for missing labs or patient lists to reach out to the patient with similar diagnosis for group visit or education sessions, or patient recalls for specific medication therapy. Data analysis is taking raw data and converting it into useful information for decision making. In other words, taking the raw data collected and asking, what does this mean? Can it be used to trend blood pressures or identify at-risk populations? One way to convert raw data obtained from within the EHR is formalizing data in a structured display. You can utilize your reports, charts, and graphs to aid in the interpretation of the raw data that you have collected. This way, you allow the data to be in a visual format to quickly identify and track trends, as well as communicate findings to team members. One important piece to remember is to always make sure your visual presentations are appropriate for the proper audience. It is best to be concise and specific with the most information for your audience. The first important decision you must make is to pinpoint an audience. Who are you presenting to and why? Quite simply, the audience is in the driver's seat. By and large, what the audience wants is what you should be giving them. You have to listen to your audiences to find and select the right narrative, language, visual, and graphic devices that will capture their attention. The model for improvement, which was developed by associates in process improvement, is a simple yet powerful tool for accelerating improvement. The model has two parts: 3 fundamental questions which aid in the setting of aims, establishing measures, and selecting the changes to be implemented. The Plan, Do, Study, Act, PDSA cycle to guide the test of change to determine if the change is in an improvement. The next couple slides will explain the model for improvement in more detail so you can utilize it in your practice. The first step is forming the right team. Including the right people on an improvement team is critical to the successful improvement effort. Teams vary in size and composition. Each organization builds teams to suit its own needs. Be sure that the team includes members familiar with all the different parts of the process. Managers and administrators, as well as those who work in the processes, including physicians, pharmacists, nurses, and frontline workers. Finally, each team needs an executive sponsor who takes responsibility for the success of the project. The second step is setting aims. Improvement requires setting aims. An organization will not improve without a clear and firm intention to do so. The aim should be time-specific and measurable. It should also define the specific population of patients that need to be affected. Agreeing on the aim is critical, so it is allocating the people and resources necessary to accomplish the aim. The third step is establishing measures. Measurement is a critical part of testing and implementing changes. Measures tell a team whether the changes they are making actually lead to improvement. Measurement for improvement should not be confused with measurement for research. For example, let's define the word purpose using both ways. When the word purpose is used for research, it refers to discovering new knowledge. However, when purpose is used for measurement of improvement, it refers to bringing new knowledge into daily practice. Same can be true about the word data. When used in the term for research, it refers to gathering as much data as possible just in case. However, when data is used as a measurement for improvement, it refers to just gathering enough data to learn and complete another cycle. In addition, there are also 3 types of measurements to be considered. These are outcomes, process measurements, and balancing measures. You should use a balanced set of measures for all the improvement efforts. For example, an outcome measure can be used asking the question, how does the system impact the values of patients, their health, and well-being? What are impacts on the stakeholders, such as payers, employers, or the community? An answer to one of those questions would be, for diabetes, the average hemoglobin A1C level for a population of patients. Another process measure example question would be, are the part steps in the system performing as planned? Are we on track in our efforts to improve the system? An appropriate finding for this measure would be, for diabetes, the percentage of patients whose hemoglobin A1C level was measured twice in the past year. And finally, a balancing measure question would be, are the changes designed to improve one part of the system causing new problems in other parts of the system? So this can be something along the lines of reducing patients' length of stay in the hospital to make sure readmission rates are not increasing. While all changes do not lead to improvement, all improvement requires change. The ability to develop, test, and implement changes is essential for any individual, group, or organization that wants to continuously improve. There are many kinds of changes that will lead to improvement, but these specific changes are developed from a limited number of change concepts. The first change concept is to eliminate waste. Eliminating waste is achieved when you look for ways of eliminating any activity or resource in the organization that does not add value to an external customer. Improving workflow is another. Improving workflow is an important way to improve the quality of the goods and services produced by those processes. Optimizing inventory is to inventory all types of possible source of waste in organizations. Understanding where inventory is stored in the system is the first step in finding opportunities for improvement. Changing the work environment itself can be a high leverage opportunity for making all other process changes more effective. An organization can gain a competitive advantage by reducing time in developing new projects, waiting times for services, lead times for orders and deliveries, and cycle times for all functions in the organization. And lastly, reducing variation improves the predictability of outcomes and helps reduce the frequency of poor results. There are many reasons to test change. These include to increase your belief that the change will result in improvement, to decide which of several proposed changes will lead to the desired improvement, to evaluate how much improvement can be expected from a change, to decide whether the proposed change will work in the actual environment of interest, to decide which combinations of changes will have the desired effects on the important measurements of quality, to evaluate costs, social impact, and side effects from a proposed change, and to minimize resistance upon implementation. The Plan, Do, Study, Act PDSA cycle is shorthand for testing a change by planning it, trying it, observing the results, and acting on what is learned. This is a scientific method used for action-oriented learning. The next couple of slides will describe this vital PDSA cycle in detail. Step 1 is plan. Plan the test or observation, including a plan for collecting data. State the objective of the test, make predictions about what will happen and why, and develop a plan to test the change. Step 2 is do. Try out the test on a small scale. Document problems and unexpected observations and begin analysis of data. Step 3 is study. Set aside time to analyze the data and study the results. Complete the analysis of data, compare the data to your predictions, and summarize and reflect on what you have learned. Step 4 is act. Refine the change based on what we have learned from the test. Determine what modifications should be made and prepare a plan for the next test. The following is a real-life example of using the PDSA cycle in healthcare. We will start with the hypothesis. The hypothesis is there a difference between blood pressures taken immediately on arrival versus blood pressures taken after a patient sits for 5 minutes with feet on the floor and arms supported at heart level? So then we applied our questions. Who will collect the data? This was decided to be a medical assistant. What data will be collected? It was the blood pressure. When will the data be collected? In the clinic during patient appointment times for 2 weeks. And finally, how will the data be collected? The blood pressure would initially be taken as the patient arrives. A second blood pressure is then assessed after the patient has had a chance to sit for 5 minutes, feet on the floor, and arms supported at heart level. The plan was then carried out. The patient was brought into a room and the blood pressure was immediately taken. After 5 minutes of rest with the patient's feet on the floor and arm at heart level, a second blood pressure was taken. The medical assistants collecting the data noted at this time that there were issues with having patients still available at the 5-minute interval. This process was disrupting workflow. These findings, the issues noted during data collection, is an important step to the PDSA cycle because the aim is process and improvement, and these issues are as vital as the data we are collecting. The findings were as followed. 45% of patients' blood pressure measured lower at the second blood pressure compared to the initial blood pressure. Of those 45%, 55% of those patients were measured hypertensive at the first reading and normal at the second reading. The mean blood pressure initial reading was 134/83, and the mean blood pressure second reading was 125/78. So now what? What changes are needed for the next cycle? We can brainstorm after collecting the data, and this is a critical step. The cycle could be expanded to collect more data, particularly data involving residents' clinic patients. The next cycle should likely include more information about the patients, their comorbidities, and perhaps a limited chart review as opposed to a very basic information collected this cycle. For example, whether or not the patient had diabetes. And the smaller sample size indicated a clinically significant difference, so further cycles are absolutely necessary. While implementation of this change to the clinic may be somewhat difficult, it can mean a substantial difference for the patient care, even down to the issues of medication versus no medication. It is up to the team to decide the next steps and their ultimate goals for the implementation of process improvement. Lastly, how can we include IT into our brainstorming solutions? Healthcare entities have all invested money, time, and education in IT to help us improve our delivery of patient care. Can we think of ways to leverage our IT to provide solutions and ideas for our next cycle of PDSA and process improvement? How about the use of manual cuffs versus automatic cuffs with data electronically transferred into a patient's record? Or the implementation of CDS, or clinical decision support, that is unique to the specific patient population, designing a workflow around patient engagement, which may include self-monitoring at home, or even the running of reports utilizing our electronic health record data to identify at-risk patients prior to our appointment time. After testing a change on a small scale, learning from each visit, and refining the change through several PDSA cycles, the change is ready for implementation on a broader scale. For example, for the entire pilot population or an entire unit. Implementation is a permanent change to the way work is done, and as such, involves building the change into the organization. It may affect documentation, written policies, hiring, training, compensation, and aspects of the organization's infrastructure that are not heavily engaged in the testing phase. Implementation also requires the use again of the PDSA cycle. In addition, spreading change is the process of taking a successful implementation process from a pilot unit and replicating the change or packages of changes in other parts of the organization. During implementation, teams learn valuable lessons necessary for successful spreading, including key infrastructure ideas, optimal sequencing of tasks, and working with people to help them adopt and adapt to a change. Spreading change efforts will benefit from the use of the PDSA cycle. Units adopting the change need to plan how best to adapt the change to their unit and to determine if the change resulted in a predicted improvement. In summary, we have identified and discussed the fundamental processes to help analyze and improve the health of your patients. The final products of these processes of improvements are the creation and updating of practice policies and protocols, creating and updating order sets, incorporating logarithms and clinical pathways for treatment, and monitoring progress toward goals. There are many ways that health IT can be leveraged to analyze and improve the health of your patients. Making the most of your technology means improving the identification of patients, improving the quality and convenience of patient care, improving the accuracy of diagnoses, and most importantly, health outcomes. Improving care coordination, maximizing team effectiveness, increasing practice efficiency, and cost saving. In short, healthcare teams should be leveraging the many aspects of health information technology to manage their hypertensive and diabetic patients. Failing to capitalize on many ways health IT can be utilized means not maximizing your return on investment. Healthcare teams owe it to their patients to ensure they're making the most of the available technology to improve outcomes. With that, we'd like to thank you for your time today. If you have any questions regarding the material we just covered or anything related to health IT, please contact us at one of the numbers or email addresses on the slide. While we give attendees time to submit questions, we'd like to take a minute or two to briefly explain the other webinars in this series and to encourage you to sign up if you haven't already. Today was the fourth installment of a four-part educational series. The first session was a high-level overview of the many ways health IT can be leveraged to identify, engage, monitor, analyze, and improve the health of your hypertensive and diabetic patients. Today's session was the last of 3 deeper dives into the material covered in the first presentation. Additional sessions take a more in-depth look into using health IT to identify your patients, followed by a presentation on engaging and monitoring patients. As mentioned, we've also developed and collected a set of tools to accompany these topics and strategies. Tools you can use to help leverage health IT to improve outcomes. These tools are available at our website at www.mcda.org, and all of today's attendees will receive an email with these tools. Thank you.